Hello everyone. In today's session, we are going to discuss about tuberculosis. It is a continuation to the chapter Epidemiology of Communicable Diseases. To begin with, the introduction to tuberculosis. It is a specific infectious disease caused by Mycobacterium tuberculosis. You can see the picture of the Mycobacterium tuberculosis given in the slide. TB is caused by this microorganism named as Mycobacterium tuberculosis. The disease primarily affects the lungs and it causes pulmonary TB. When the lungs are infected with TB, it is referred to as pulmonary TB. It also affects the intestines, meninges, bones, joints, lymph glands, skin, and other tissues of the body. You can see the picture of the meninges being infected. So the Mycobacterium tuberculosis has the capacity to infect even the other organs of the body like the meninges in the brain, intestine, bones, joints, lymph glands, skin. The disease is usually chronic with the varying clinical manifestations. So the clinical manifestations will be dealt in the upcoming slides. So we know that the disease is usually found to be a chronic disease. TB is a chronic disease, infectious disease, primarily affects the lungs. It can also affect the other organs. The disease can also affect the animals like cattle. This is known as bovine tuberculosis. So what is bovine tuberculosis? When the TB affects the animals, it is referred to as bovine tuberculosis, which may sometimes be communicated to the man again by meat, infected milk, or various other reasons. So we see that the bovine tuberculosis, the TB affecting the animals, can indirectly affect the humans as well. So it can be communicated to the man, and the animal will also present with the enlarged lymph nodes and a small gritty pale yellow lumps which are seen on the surfaces of the lungs. You can see the picture here, the TB affecting the lungs of the animal, and he also presents with weight loss. Coughing is seen in the last stages. Moving further to the problem statement. So in the epidemiological aspect, we will discuss all the problem statement, epidemiological indices, and we will discuss about the natural history of the TB, followed by, if the time permits, we will continue with the tuberculin test in the further slides. For now, let's begin with the problem statement. World TB remains a worldwide public health problem. So the tuberculosis in the world, we see that it is in the world, okay, in world, TB remains a worldwide public health problem, despite the fact that the causative organism was discovered more than 100 years ago. The causative organism is discovered. In the first place, we know the causative organism. Secondly, the highly effective drugs and vaccines are available. So we see that the vaccines are available, the drugs are available, the two highly effective vaccines and drugs are available. Though the causative organism is discovered 100 years ago, and the effective drugs, vaccines are available, making TB a preventable as well as a curable disease. But even today, despite of these facts, it is still a worldwide public health problem. It is estimated that about 1/3 of the current global population is infected asymptomatically with TB. Don't forget the point, it is asymptomatically affected with TB. 1/3 of the global population, okay, divide the world's population into 3, out of which 1/3 is asymptomatically affected with TB. Patients with infectious pulmonary tuberculosis disease can infect 10 to 15 persons in 1 year. So if one patient is affected with the TB, he has the capacity to infect 10 to 15 persons in 1 year. Drug resistance is continuing to be a public health crisis. So the drug resistance which the individuals, infected individuals develop, that is a public health crisis. Globally, in 2017, 6.7 million people with TB were notified to the National TB Program, and they were reported to the World Health Organization. How many? In 2017, 6.7 million. Let us note down here. In 2017, 6.7 million people were reported with the TB to the World Health Organization and to the National TB Program. Of these 6.4 million had incident episodes of TB. So out of this 6.4 million were having incident TB. Now what is incident episode of TB? A new case of a TB or a relapse case of a TB is referred to as an incident case. Of the 10 million estimated cases, so as on the whole they estimated that 10 million people were suffering with TB. Of the estimated 10 million cases of TB, only 6.4 were notified. There is a gap, so only 6.4 were notified. So the gap of 3.6 million between the estimated cases and the reported cases is because of the underreporting and the underdiagnosis of the cases. Are you understanding? Let us zoom in here and write it again. So what are they saying? Totally estimated cases were 10. Okay, estimated cases were 10, out of which only 6.4 were reported. These were the reported cases, these are the estimated cases. So there is a gap of 3.6 million cases. So what is the reason for this gap in the recording of the cases? Where are these cases going? They are not reported. Why are they not reported? Because of the underdiagnosis of the cases and the under reporting of the cases. In 2017, estimates for TB associated death were 1.3 million. So the estimated TB deaths in 2017 was 1.3 million and the cases were 6.7 million. Though India appears to be the major source of the region's TB numbers, that is 2.84 million. So we see India is a major source of region's TB. We see the TB, India is a major source of the region's TB. 2.84 million cases are reported. It actually ranks number 6 in terms of incidence rate. So the number of new cases we have, that is 6 in terms of incidence rate. We have the mortality rate also. India obtains the 6th position due to the TB. The mortality rates due to TB, the death rate, mortality rate is nothing but the deaths which are occurring due to TB all around the world. We have India obtaining the 6th position. Even in cases of the incidence cases, that is the new cases which are occurring, 2.84 million were reported and it ranks 6th in number. If the mortality death rate also is 6 in number. In many developing countries, the acquired drug resistance is very high. So we see in the developing countries, the drug resistance remains to be very high because the national TB control program in these countries have not been able to achieve a high cure rate over a very long period of time. Since the drugs have been utilized for a very long period of time, and even though they have been utilized for a long period of time, these developing countries have not been able to achieve a cure rate, high cure rate. As a result, there is a resistance which have developed to these drugs. For the past 2 decades, national and international efforts in TB prevention, diagnosis, and treatment have been guided by the DOTS strategy. A very important aspect when we were discussing about the health programs in India, where I discussed about the TB control program. National Tuberculosis Control Program. In that, I have explained about the DOT strategy. Let's just brush through now. You can just check it in the playlist, in the SPM playlist, and also the separate playlist of each chapter is also given. Therein, you can find the DOT strategy. So, the TB prevention, diagnosis, treatment is guided by the DOT strategy. It was started in the mid 1990 and it ran up to 2005, and subsequently the Stop TB strategy was initiated in the year 2006, and the coverage was up to the year 2015. So we see that the DOT strategy and Stop TB strategy, they are focusing on the TB prevention. It is both national and international efforts for the TB prevention, for the TB diagnosis and the treatment. It is guided by the DOT strategy and Stop TB strategy. The core of the strategy was DOTS, the World Health Organization's End TB strategy, adopted by the WH Assembly in May 2014. So now we were discussing about the DOTS. I have explained in detail, you can check, and Stop TB is also explained here. They have given that what is Stop TB. It is nothing but a blueprint which is given to all the countries head to end the TB epidemic by driving down the TB deaths. So what are they giving? A blueprint is given to the authorities and of all the countries, so that they can end the TB epidemic by lowering down the TB deaths, TB incidents, and eliminating the catastrophic cost of the TB. So we see that TB is a disease which can have a catastrophic cost on the family, where the financial burdens are exceeding the 20% of the household's income. When the more than 20% of the household's income is utilized for the treatment, then it is considered to be a catastrophic cost. TB is a disease which results in the catastrophic cost. So we need to, there is a blueprint which is given to the countries so that they can reduce the catastrophic cost, they can reduce the incidents and the TB deaths. India is the highest TB burden country in the world. So we see that TB in India is the highest burden, and it is ranking in the world, 6th position. The age distribution. In India, TB is more prevalently seen in the adults than in the children. It affects the adults in the most productive age group. First, primarily, it affects the adults. Compared to the children, the adults are affected. Secondly, it is in the adults. Which age is predominantly affected? The reproductive age group, that is 15 to the most productive age group, that is 15 to 54 years. So we have this table which is given in the Park's textbook of preventive medicine. We have the percentage of new smear positive cases in the different age groups. You can see the highest percentage is noted in the age group from 15 to 54 years. Okay, 20, 22, 20 and 16. So the highest rates are found in the age group 15 to 54. Even in that, the age group of 25 to 35 are having the highest number of cases, that is 1,33,386 cases and 22.50%. And the economic and social burden. The economic and social burden of disease. TB primarily affects the people in their productive years of the life, where 2/3 of the cases are male. So you can see the economic burden which it is producing on the family, since the productive age group is affected. And we see that it is also affecting the productive years, and especially the males. So the family in Indian households in the developing countries like India, the males are bearing the family burden on a greater level, especially in the rural side. Nowadays, since the advances have occurred, even the females are contributing equally to the family's burden. Here we generally see that the 2/3 of the cases are males, and they are mostly affecting the productive years of the life, and it is causing a more social and economic burden on the society. TB kills more women in the reproductive age group than all causes of maternal mortality combined. and it may create more orphans than any other infectious disease. Is it clear? What happens in India? TB is mainly a disease of the poor. HIV increases a person's susceptibility to TB infection. It increases the morbidity, mortality in HIV infected persons. HIV is the most potent risk factor also for the progression of the TB infection to disease. So let us discuss in a little detailed form to have a clear understanding. So we see that in India, TB is mainly a disease of the poor. Primarily, what did we see? First thing, in the males, one third of the TB infected patients are male. And in females, infertility is caused. And the direct indirect impact of TB on the children is we have 3 lakhs children of tuberculosis patients who leave the school and they take up the employment to support their families, and this is how there is an economic and social impact on the society. And also, we see that a patient of TB on an average will take 3 to 4 months to recuperate, and that is how he's losing much of the income. It takes almost 3 to 4 months for a patient to recuperate back. As a result, there is much loss of income, and this loss will be very disastrous to those who are struggling against the poverty. So the TB is mainly a disease of the poor because the person is not able to carry out his source of income is lost because he's not doing his job. He has to stay home, he has to stay in the hospitals, he has to spend up to 3 to 4 months, and this loss is very disastrous to those who are struggling against the poverty. They are most likely to be they are defaults in the treatment, and the vast majority of the economic burden in India is caused by the loss of life rather than the disease. Because of the loss of life, there is more economic burden which is seen in the people. And next comes the HIV. So, what generally HIV does? HIV will weaken the immune system of the patient. It will make it very hard to fight off the tuberculosis, and it will increase the risk of developing TB in the patients who are already suffering with HIV because their immune system is completely weakened. Here you can see HIV is increasing the susceptibility. So, one, it increases the person's susceptibility. It increases the morbidity and mortality in HIV infected person. So now the HIV infected person has a greater chances of mortality after being infected with TB as well. HIV is the most potent risk factor for the progression of the TB. Once if the patient is affected with TB, additionally if he is suffering with HIV, what happens is it will increase the progression of TB infection to the disease. So what's happening? HIV is a risk factor for progression of TB. HIV indirectly is increasing the TB. Is it clear? The slide is clear? Now we move further to the epidemiological indices. And the thing you need to know is the poor people. Who are those poor peoples? Majority of victims will be those residents who are there in the backward areas, in the tribal pockets, like poor living conditions. Those people will be majoritively in being affected with TB. Those slum dwellers, laborers, migrants, they are the most widely spreading the disease, and they'll be mostly infected with TB. High risk groups. Moving further to the epidemiological indices. What is indices? Indices are the parameters. Indices is nothing but the parameters which are needed to measure the TB problem in the community, as well as for planning and evaluating the control measures. So what is indices? These are the parameters we use. Why do we use this parameters? So that we can plan the treatment, we can evaluate the control measures what are taken, we can evaluate them how effective they are, and they are required for international comparisons as well. So let us begin with Incidence. Incidence is defined as the number of new and recurrent or relapsed cases of TB occurring in a given year. We've already discussed this. What is incidence? New cases plus the cases which are relapsing. Recurrent episodes. Recurrent episode is defined as a new episode of TB in a people who have had TB in the past. So we see that recurrently. Very simple words. You just need to apply the basics here. Incidence is what? New plus relapse cases. Recurrent is there is a appearance of new episode of TB in a patient. New episode has come in a patient who had TB in the past, and once he had TB, for whom there was bacteriological confirmation of cure. We know that once the signs and symptoms subside, we perform the test and we need to confirm bacteriologically, we need to confirm that the patient is cured of TB. Documentation is given that the treatment was completed. So, recurrent episode is a new episode in a patient who had the bacteriological confirmation to cure and he had the documentation that the treatment was completed. Prevalence. Then comes prevalence. Prevalence is defined as number of TB cases, that is all forms of TB. May it be old cases, new cases, relapse cases, all the forms of cases at a given point in time. What is prevalence? Old cases plus new cases. The new, excuse me, I don't know why, there's some throat irritation. So we see that prevalence is defined as the number of TB cases, all forms at a given point in time. The age specific prevalence of patients is considered the most relevant index. So we see that the age specific prevalence is taken, which is the most relevant. So we have discussed about the prevalence of the cases, age specific. In 15 to 54 years, the cases were found to be very high. Mortality from TB is defined as, now we're seeing the mortality. We know what is mortality. Mortality is the death. Mortality from TB is defined as number of deaths. You can see it is defined as number of deaths caused by TB. In a HIV negative people, according to the latest revision of International Classification of Diseases 10, TB deaths among the HIV positive people are classified as HIV deaths. So we see that a person suffering with TB, one, he could have TB HIV positive, or he could have HIV negative, and the patient's death. So now how do we classify it? A patient died and he was having TB negative, classified as mortality from TB. The patient died, he had TB positive. The patient died from TB and also having HIV positive. He is classified as in the HIV deaths in ICD-10. The case fatality rate is the risk of deaths from TB among the people with active TB disease. So what is case fatality rate? The case fatality rate is the risk of death from TB among the people with active TB disease. The deaths are occurring among the people who are having the active TB disease is the case fatality rate. Okay, that is the mortality. And this is case fatality. Case fatality, active TB cases and the death has occurred. The case notification rate. Now we are studying about the case notification rate. It refers to new and recurrent episodes of TB notified to the World Health Organization in a given year. We are reporting the new cases plus recurrent cases to the World Health Organization in a given year, and it is expressed per 1 lakh population. And this case notification rate is expressed per 1 lakh population. Case detection rate. The case detection rate is calculated as the number of notification of new and relapse cases in a year divided by the incidence of such cases in the same year. Are you understanding? Case detection. the number of cases, okay, the number of cases in that year, in that same year, number of incidents. Wait, let me just write it properly for you. So we have case detection rate. It is calculated as number of new plus relapsed cases in a year. Okay, number of new plus relapsed cases in a year, and this new plus relapsed cases is divided by the estimated incidence. It is divided by incidence. What is incidence? The new plus relapse cases in the same year. Prevalence of drug resistance cases. It is the prevalence of a patient who are exerting tuberculosis. They are excreting the tubercle bacilli resistant to anti-tuberculosis drugs. So we see that the prevalence of drug resistant. They are drug resistant, so they are resistant to the anti-tuberculosis drugs. Very simple. And it is the prevalence of a patient who is excreting the tubercle bacilli. He is still excreting the tubercle bacilli but resistant to the anti-tuberculosis drugs. Is it clear? It is the prevalence of a patient who is excreting the tubercle bacilli resistant to anti-tuberculosis drug. The tuberculosis bacilli resistant to, he is resistant to anti-tuberculosis drugs. Is it clear? Moving further to the case definitions. A bacteriologically confirmed TB case is the one from whom a biological specimen is positive by smear microscopy or culture. So we see that a bacteriologically confirmed TB. You can see bacteriologically confirmed. What does it mean? A biological specimen was collected and this specimen turned out to be positive. When we did the smear microscopy or we did the culture, it turned out to be positive. So it is a bacteriologically confirmed case. Then comes clinically diagnosed TB case. Clinically diagnosed is the one who does not fulfill the criteria for bacteriological confirmation but has been diagnosed with active TB by a clinician. So we see that the physician has concluded it to be TB. But when we did the bacteriological confirmation, he does not fulfill the criteria. Or the clinician or any other medical practitioner has decided to give the patient a full course of TB treatment. So who is a clinically diagnosed TB? One, the clinician has diagnosed it to be TB. Second, a medical practitioner or a clinician, physician, he has decided to give the patient a full treatment of TB. But he does not fulfill the criteria of bacteriological confirmation. Bacteriologically confirmed or clinically diagnostic cases of TB are also classified according to the anatomical site of the disease, history of the previous treatment, drug resistance, and HIV status. So we see that this definition, we are first defining the cases diagnosed on the basis of X-ray abnormalities, histology, extrapulmonary cases. So these clinically diagnosed cases, we have confirmed about it. We have finished about it, where this clinically diagnostic cases, this definition is also including certain things, that those cases were diagnosed on X-ray. One, the patient has the physician has clinically diagnosed and he has used the X-ray, and based upon the X-ray abnormalities he has diagnosed the case, or there is a histology which is suggesting the diagnosis, or there could be some extra pulmonary case without the laboratory confirmations. Okay, now we are going to study about the classification. We are starting with the classification of TB. One, about the clinically diagnosed or not is the first thing. It is bacteriologically confirmed or it is clinically diagnosed. These are the two things which we saw in the previous slide. Now we will see how the TB is classified further. TB is classified based upon the anatomical sites. Okay, it is based upon the anatomical site of the disease. It is based upon the history of the previous treatment. One, the site, okay, anatomical site of TB, the treatment, history of previous treatment, the drug resistance, and the HIV status. Is it clear? Four things. What are those? Based upon the one anatomical site. Just remember the lungs anatomical site. Second, based upon the treatment, HIV status and drug resistance. Soon after treatment, you can remember drugs. In drugs, you have to remember drug resistant classification. Let us begin with classification, which is based upon the anatomical site. So, pulmonary TB. It is referring to bacteriologically confirmed or can be clinically diagnosed case of TB which is involving the lung parenchyma. So here the pulmonary TB, by the word pulmonary itself you can make out that the lung is involved. Pulmonary is the lung, especially the parenchyma is involved here. Miliary TB is classified as pulmonary TB because there is some lesions which are found in the lungs. In miliary TB as well, we see that the lesions are found in the lungs. Hence, it is falling under the pulmonary TB. Next, we have extrapulmonary TB. Extrapulmonary TB refers to any bacteriologically confirmed or the clinically diagnosed case of TB which is involving the organs other than the lungs. So we see extrapulmonary. The words you just have to remember: pulmonary, extrapulmonary. Pulmonary involving the lungs, extrapulmonary involving organs other than lungs. Very simple. What are the other organs now? You can start mentioning the other organs. It can involve the pleura, it can involve the lymph nodes, abdomen, genitourinary tract, skin, joints, bones, meninges. You can capture this picture. So we see that it is involving the brain. We have the pleura, liver, genitourinary tract, gastrointestinal system, bones, joints, okay, abdomen, even the brain, and the brain meninges. Is it clear? Now we're moving further to the classification which is based upon the history of the previous TB treatment. So how do we classify the patients based upon the previous treatment, the history of previous treatment? New patients and previously treated patients. What are the two classifications we see? New patients, previously treated patients. New patients are those patients who have never been treated for TB or they have never taken anti-TB drugs for less than a month. So they have never been treated for TB, they have never taken anti-TB drugs. They are the new patients. Now comes previously treated patients are those who have received the anti-TB drugs in the past for 1 month or more. They have never received the treatment for less than a month. Here they have received treatment for 1 month or more, that is anti-TB drugs. They are previously treated patients. Now we move further to the classification which is based upon the drug resistance. We have monoresistance, polydrug resistance and multidrug resistance. Mono represents what? Single. Mono resistance is resistance to one first line anti-TB drug. So there is resistance to just one anti-TB drug. That is the first line anti-TB drug. Just one, mono resistance. Polydrug resistance is resistance to more than one. There is resistance to more than one first line anti-TB drugs other than both isoniazid and rifampicin. So we see they have resistance to more than one anti-TB drugs, isoniazid and rifampicin. Multi-drug resistance to at least both isoniazid and rifampicin. Multi-drug, right? So it is both isoniazid and rifampicin is involved. Okay. Now, classification continuing, we have extensive drug resistance to any fluoroquinolone and at least one of the 3 second line injectable drugs. In addition to the multi-drug resistance, there is also resistance to second line injectable drugs. That is extensive drug resistance, extensively drug resistance, because even the second line injectable drugs, they are resistant. So what are those second line injectable drugs? We have capromycin, kanamycin, and then amikacin. Okay, capromycin, kanamycin, and amikacin, these are the second line injectable drugs, and these people are resistant to the second line injectable drugs along with the multi drug resistance. Then comes specific rifampicin resistance. Resistance to rifampicin with or without resistance to other anti-TB drugs. It can be rifampicin plus isoniazid or second line drugs like capromycin, amikacin, kanamycin. It can be resistance to rifampicin with other drugs or just resistance to rifampicin without the involvement of resistance to other drugs. Now comes the classification based on the HIV status. HIV positive TB patient. HIV positive TB patient refers to any bacteriologically confirmed or clinically diagnosed case of TB who has a positive result from HIV. So he is either clinically diagnosed or he might be bacteriologically confirmed, either of the two, but the patient is tested positive to HIV. Then comes HIV negative patient. In HIV negative TB patient, he is any patient who is bacteriologically confirmed or clinically diagnosed case of TB who has a negative result of HIV which was conducted at the time of TB diagnosis. Very simple. See, TB patient. He is HIV positive, he is HIV negative. And HIV status unknown TB patients. So HIV status unknown TB patients are those, they refer to any bacteriologically confirmed or clinically diagnosed case of TB who has no result of HIV testing. Okay, he has no results of HIV testing. Moving further to the treatment outcome definitions. The new treatment outcome definitions make a clear distinction between the two types of patients: patients treated for drug susceptible TB and patients who are treated for drug resistance TB using the second line treatment. So we are making the treatment outcome definitions here. Distinction is made between the two patients. One, they are treated for drug susceptible TB. This TB which they are suffering is susceptible to the drugs. The other one is resistant to the drugs. Defined as a combination chemotherapy for drug resistance tuberculosis, it includes the drugs other than the first line drugs. So we have combination chemotherapy. It is defined as combination chemotherapy for the drug resistant tuberculosis because it is including the drugs other than the first line drugs. Now we move further to the natural history of tuberculosis. To begin with, the agent factor. The Mycobacterium tuberculosis is the agent factor here. You can see the picture of the Mycobacterium tuberculosis. It is a facultative intracellular parasite. It is a facultative intracellular parasite which is readily ingested by the phagocyte, and it is resistant to the intracellular killing. Since it is an intracellular parasite, once it is affected, it will be ingested by the phagocytes and it becomes resistant to the intracellular killing. You can see facultative intracellular parasite ingested by phagocyte and it is resistant to the killing. Of importance to the man are the human strains and the bovine strains. So we have studied about the bovine strains and the human strains. The human strain is responsible for the vast majority of the cases, and the bovine strain is affecting mainly the animals like cattle and other animals. And we have further the source of infection. Is it clear? The agent, what you have to remember, is the Mycobacterium tuberculosis, of which the human strains and the animal strains are important. Humans causing the TB, and in animals the bovine tuberculosis is seen, and again it is caused by Mycobacterium tuberculosis. Moving further to the source of infection. The source of infection, there are two sources of infection, human and bovine. Human source, the most common source of infections in the human cases whose sputum is positive for tubercle bacilli. So we see that human case is the main source of infection. A human case which is positive to tubercle bacilli, who has either received no treatment or who has been fully recovered or fully treated, he is the main source of infection. The bovine source of infection is usually the infected milk. In India, from the average of 2%, we have okay, we'll discuss it in the next slide. See, we have the communicability here. In the communicability, the patients are infective as long as they remain untreated, they are infective. So as long as they are untreated, they remain infective. Moving further to the host factors. The age group, it affects all the ages. TB is affecting all the ages in India from an average of 2% in 0 to 14 age group. So we see that the infection rate is 0 to it is 2% in 0 to 14 age group, and it is climbing up to 20% in the age group 15 to 24. In the age group of 15 to 24, it is 20%. You can see how the rate has climbed up, 2% to 20%. In the primary children, that is 0 to 14, the primary age group, it is 0 to 14 age group, it is 2%, whereas in the age group of 15 to 24, it is 20%. Moving further to the sex, it is more prevalent in the males. So we have the males who are more affected with TB. And then we come to the nutrition. Malnutrition is predisposing the patients to TB. And then immunity. Man has no inherited immunity against TB. So we see that man has no inherited immunity against the TB, and the immunity is acquired as a result of the natural infection, or the immunity can be acquired from the BCG vaccination. The past infection with atypical mycobacterium is also credited with certain amount of naturally acquired immunity. So we see that it is also credited with the naturally acquired immunity, or from the vaccination, or the natural infection which has occurred in the past. Next, we have hereditary. That is what we saw, that TB is not a hereditary disease. However, when they performed the twin studies, it indicated that the inherited susceptibility is an important risk factor for TB. It is not a hereditary disease. Yet, the twin studies indicated that there is inherited susceptibility can be considered as an important risk factor. The susceptibility, okay, the decreased immune system, okay, the lowered immunity in the parents can also affect the children, and thereby they can become susceptible to TB. Moving further to the social factors. Tuberculosis is a social disease with medical aspects. It is also known as a barometer of the social welfare. The social factors can include many non-medical factors. The non-medical factors which are stated here are poor quality of life. So we know that the social factors which are responsible for TB is the poor quality of the life, the poor housing, the overcrowding which is seen in the slums, in the backward classes, and the population explosion, undernutrition, malnutrition, smoking, alcohol abuse, and the lack of education. Even if the person is infected, they do not isolate the patient. There is no place left for isolation. There is overcrowding which is seen in the slums in the backward areas. So what happens there? There is no room for ventilation, no room for proper hygiene. So the patient is not isolated, thereby he is spreading the infection. population because of the poor quality of life and the large families, early marriages. Again, early marriages is leading to overpopulation, lack of awareness of cause of the illness. They don't know what is the cause of the illness, they don't know the preventive measures, and also they don't have that opportunity to afford the medical facilities. All of these factors are interrelated and they contribute to the occurrence and spread of the TB. Moving further to the mode of transmission, it is transmitted mainly by the droplet infection and droplet nuclei. It is generated by sputum positive patients with pulmonary TB. So we see that the sputum positive patients, so these patients who are suffering with pulmonary TB and they are positive in the sputum smear, and sputum positive microscopic patients, they will be generating these droplets which are containing the infectious organism. The droplet infection and the droplet nuclei which is generated by the patient suffering with the tuberculosis. To transmit the infection, the particles must be fresh enough to carry a viable organism. This is important. Just to transmit the infection, the particles should be fresh. The coughing will generate the largest number of droplets of all the sizes. The frequency and the vigor of cough, the frequency of cough and the vigorousness of the cough and the ventilation of the environment is also influencing the transmission of infection. As I told you earlier, it is the social factors are also playing a important role along with the medical factors. So these social factors like the ventilation of the environment is also influencing the transmission of infection. The incubation period of time from the receipt of infection to the development of positive tuberculin test, it is ranging from 3 to 6 weeks. So the incubation period, the time of infection to the development of positive tuberculin test. What is the incubation period here? 3 to 6 weeks. The development of the disease will depend upon the closeness of the contact, the extent of the disease or the severity of disease in the patient, and the sputum positivity of the source. The incubation period can range from weeks to months to years. So, why is the incubation period so long in TB? It is ranging from weeks, months, or years. It is because in the Mycobacterium tuberculosis, the generation time is 792 to 932 minutes. You can see the generation time here. It is ranging from 792 to 932. Okay, 800 to 900 minutes. Whereas in other microorganisms, the generation time like coliform bacilli like E. coli and other medically important bacteria, it's just 20 minutes. And you can see here the staphylococcus aureus, it is just 30 minutes, 20 minutes. So the generation time is very less in other bacteria, whereas in the Mycobacterium tuberculosis, the generation time ranges from 800 to 900. In the next session, we will start about the control of TB, and we will continue with tuberculin test, Mantoc test, and further topics will be discussed in the upcoming parts of the videos. I hope this session is clear, and if you like the video, hit the like button and subscribe. And this video was captured based upon the request of a subscriber. She had commented in the comment section. I specially made this video based on her request. Thank you.